Well, good afternoon and welcome back. It was a great lunch with cookies and sandwiches and wow, I'm pretty full, but we have some excitement coming for you, right? You're in the session, Don't Let Trauma Informed Be Traumatic. Universal best practices. Many agencies require clients to complete ACEs screeners within the first few appointments, sometimes conducted by a practitioner who does not have a relationship with the client or significant training in trauma-informed care. The potential re-traumatizing questions are a prerequisite for receiving services, and yet data from ACE screeners are rarely used to inform or change services for individuals. This session will present the case for implementing universal best practices instead of repeating the ACE questionnaire. This session will present information from current trauma-informed care experts that explains how the ACEs questionnaire can be potentially traumatizing for clients and should not be used indiscriminately. Participants will learn how the ACEs study informs universal best practices that can be applied in nearly every treatment setting for every client and service provider. Universal best practices include increased predictability, increasing client control, increasing opportunities for self-regulation, and increasing culturally responsive treatment practices. Participants will be invited to examine the use of the ACE questionnaire within their own agency and how universal best practices can be implemented in their field. So we're very fortunate to have two experts in this field. We're excited to have them here. Jesse Schroeder, he, him, are his pronouns. LISW-S is the lead community trainer of Building Better Lives and has the privilege of working with children, students, and families in the Central Ohio area for over 16 years. Sorry. I kind of scared you a little bit, like 30 what? No, 16 years. And he's a graduate of the MSW program at the Ohio State University and studied religion at Lee University in Cleveland, Tennessee. He lives in Grove City with his wife, 2 daughters, and a dog. He enjoys playing music and getting outside. We also have Debbie Jones. Her pronouns are she, her. MHA is in her 6th year with Family and Children First Council and 3rd in Franklin County alongside the BBL team, which focuses on trauma, competency, and resilience-based practices. In her, she's got quotes, parentheses, very limited free time. You'll find her hiking, road cycling, or having dance parties with her 4 children. Wonderful. Debbie is also in her 1st year as a PhD student in educational policy, as well as her 2nd semester of her 2nd master's. Note, her 2nd semester of her 2nd master's in the field of law studies, both degrees at the Ohio State University, as well as Jesse. Debbie has a long-term goal of impacting policy around the school to prison pipeline and other systemic reform. Wonderful. Thank you so much for coming. We'll have you come up and present. All right, welcome.
Thank you.
Thank you for that introduction.
Thank you all for your patience too, online, in person. I'm going to try to find my way in this camera here. So, do you need to do something on here while I'm doing it?
You can see the presentation.
Thank you. I was about to do that. So helpful. I think it's right here.
Oh, yes, you're right.
Mhm.
Or we can just take it off.
That's fine too. All right, so thank you so much for being here today. We appreciate those introductions. We appreciate spending time with all of you. We appreciate those in the room who are able to give us some of their background and introductions and tell us who they are and coming to this work from. As mentioned, we are with the Family and Children First Council, specifically the Building Better Lives Initiative. You'll hear us refer to those things as BBL or FCFC as we move forward, just because it's a lot of repetition, right? So we were with the BBL initiative, which, as we said, is really focused on shifting from a trauma-informed practice to a trauma-competent practice. And we really use that language because informed is about knowing the stuff, right? You all in this work, in these fields you are in, are probably trauma-informed. You've been to a trauma-informed training, you do trauma-informed work. We're trying to shift that to trauma competency because that's how you apply that content, right? So there's a difference between knowing all the things and putting it into practice. And so through all of that and through all of our research, we feel like the expansion of understanding ACEs is really relevant. And I appreciated Dr. Wade this morning kind of touching on that and saying ACEs is a first step, right? And then resiliency is that second step. And so you'll hear a lot of those similar themes. We might phrase them differently, add a little bit more context to it. You might hear it a little differently as we keep going, or it might resonate differently. But as we go, if you have questions in whatever format you're supposed to ask questions, please do so. Happy to take those. You're not going to derail us in any capacity. We'll follow you down the rabbit hole and then pick back up. That never bothers us. So let me see if I can click here. How's this? And so our agenda today is we're just going to review those key implications. So we're not going to get too deep into the ACEs study. Dr. Wade did a great job of that. We're going to add just a couple of tidbits to that. And then we're going to identify potential concerns about that ACE screener and move on to how universal best practices is actually what we believe is the approach that you should use in thinking about ACEs screeners, or how you're using that within your work. So that 10-question questionnaire, which we all know by heart now, right? We know all the questions on these 10 screeners. We know that that happened in abuse, neglect, and household dysfunction. But, and you heard a little bit of this morning, what's really important about that original study, that 18,000 participant study, is that ACEs are more common than we previously thought. Like Dr. Wade said, in that original questionnaire, 66% or so of participants answered yes to at least one ACE, right? And due to underreporting, that number is actually likely 2 or more. And there was actually a 50% chance that number was 3 or more. That's really important. ACEs are more common than we previously thought. And as the replications of those studies have happened, you can see in all of that CDC information that has lended similar results, that dose response correlation of the more you answer yes to, the more likely you are to have a lot of health outcome disparities, a lot of social disparities, a lot of behavioral disparities, right? And we saw how that continuum went up all the way across the board by answering yes to more of those questions as you went. But ACEs continue to impact that physical, mental, and behavioral health throughout the lifespan. But really, the underlying thing is that in that original study, doctors Anda and Folletti, they listened to their patients, right? Because prior to coming together to doing this study, they were on opposite sides of the country, right? Dr. Anda was studying smoking cessation, while Dr. Folletti was studying weight loss in California. So they were on opposite sides of the country, recognizing that as they helped people lose weight or stop smoking, a majority of those individuals went back to those coping mechanisms, went back to food, went back to smoking, went back to something, right? And they couldn't figure out why. So what kicked this study off and the bringing of them together was listening to those people they were surveying and recognizing that there's more to the story than what's on this questionnaire. And listening was the key in all of that. And you're going to hear us come back to that theme as we go. So in these replicated findings, I told you this study's been replicated time and time again over these last 30 years, right? Different subsets, different genders, different religions, creeds, races, socioeconomic status, you can name anything, and you're going to find some replication of this study and finding those dose response correlations. So in those replicated findings, between 2011 and 2014 nationwide, 214,000 respondents came to the ACE questionnaire. That's a lot, right? That means that this study has had a lot of validity, a lot of credibility, and a lot of accountability in how it's being replicated. And that's why we continue to come back to it as a foundation. That's important. And the prevalence, again, was similar to that original ACE study in that nearly 2/3 reported at least one ACE. But we have to remember underreporting is a thing, right? Especially when you're thinking about how vulnerable those questions were. Doctor, if I'm going to the doctor, I'm probably going to admit to one of those original 10. I'm probably going to say it's too much to say I have 3 of these. What does that mean for me? What does that mean about me? That's too vulnerable, right? So we have to remember and be cognizant that even though people are saying at least 1, there's an 87% chance that that's 2, and there's a 50% chance that that's 3. And then ACEs are common across all populations, and there is a dose-response relationship. And so we come back to that term dose response because it's not cause and effect. It is the more you have, the more likely you are to. However, ACEs are not destiny, right? There's room for that wiggle room in there, that's not your determined outcome. So that's what we really want to focus on, especially as we move into these resilience things later. But this is just to kind of bring back that ACE questionnaire, really get into that, and kind of talk about those underlying things that maybe we didn't cover this morning or so far today. You want to jump in here? You want me to keep going?
You can keep going.
And so the original ACEs study kind of stopped at this bottom part, right? Normally this looks green, but where it says adverse childhood experiences, this was our original understanding of what ACEs did, which you've seen in lots of charts, right? About how this impacts health, how this impacts social, and leads to, just like Dr. Wade said this morning, up to 20 years less in terms of a life expectancy. That was our original understanding of ACEs. However, just like that replication with the Philadelphia Urban ACEs study in 2012 and 13, our understanding of ACEs has changed. And that we cannot begin to talk about adverse childhood experiences without starting to contextualize that. People are also a product of their environment, right? And we have to talk about social conditions and local context. Environment is very impactful to how somebody grows up, right? And the environment in which they surround themselves, the people, the places, geographically, all of those things are in that second tier down. And then that last one, we have a whole other training on this, so I'll try not to spend a lot of time on that. I get on a soapbox a little bit, so I won't do that for you today. But we also have to talk about historical trauma and generational embodiment. You heard a little bit of that this morning too, about molecularly passing that down from a mother to a baby. That happens a lot. And we can think of subset of population of marginalized communities and peoples that have undergone, land being taken away and being put into chattel slavery, about being members of the Holocaust and lots of anti-Semitism. We saw a lot of things this summer with the Asian American Pacific Islanders and violence being brought against that community. And what's important is we talk about that as if that's history and not as if that's things that are happening now also, right? And so as we're thinking about trauma and the true impact of trauma, yes, historically these things happened, and because they happened historically, it impacts environments in which people live now, right? Because of how historical trauma played out for populations of marginalized people, redlining is a thing geographically and impacts who can have housing where. So that moves up into that social condition, local context, right? Which domino effects into those ACEs, which goes all the way up to that pyramid. And like I said, I can get real passionate about this. We could spend the entire rest of this time on this slide, and I would, but I won't today. Do it. That's what we're getting in the background here. I know you guys online can't hear it. Another time we'll do that. But it is really important that we're thinking about historical trauma not as just history, right? How is this playing out now? And usually when we're talking about this, I tend to tell people when I got into this work, I used to think ACEs was the root cause, right? That was my first perspective shift, was that heart disease and heart attack aren't the cause, like that's the symptom. We think of that as a cause. I challenge you to think about that as a symptom of ACEs, right? That's the thing that happens because of ACEs, that dose response correlation. Now, if that registers, I'm seeing a lot of head nods here. Hopefully that's happening on the other end of the computer too. But now I'm challenging you to shift that perspective even further. ACEs is a cause, but the root cause is historical trauma and generational embodiment in which people have sustained for lots and lots and lots of years that have led to this domino or ripple effect that now lead up to this early death of up to 20 years. It's important, right? So now that I brought everybody really down, I'm going to turn it over to Jesse to bring it up. So
Thanks.
yeah.
Oh, great.
No problem. You're welcome.
Okay, wonderful segue and challenge there. We have one more kind of slide and graphic that just kind of touches base on how we think about how adverse experiences lead to this unpredictable, severe, and prolonged stress, or what's sometimes called toxic or chaotic stress. This comes from Dr. Perry's work with the neurosequential model network. And so we recognize that exposure to adverse experiences and that historical trauma that Debbie was talking about leads to that vulnerability. So what I kind of want to then shift us into right now is kind of changing gears a little bit, because the real question is, if this is the information that we have, that we're in agreement on, the science has been replicated, the studies have been replicated, and we're having conferences where the impact of early adversity is not really being debated. What do we do from here? As practitioners, as policy designers, as public health specialists, how do we take this information and use it to best inform practices and services, particularly for our clients? And so the conversation that's going to follow is really thinking about how does that service provider client interaction, how does that go, and how can we be really cognizant of avoiding re-traumatization? What I have seen happen over the last several years, really 8 to 10 years as I've kind of studied adverse childhood experiences and trauma, is that people get really excited about the ACE study. It's easy to latch onto because it's a simple number. There's a simple correlation between the more ACEs, the more adversity, the more concerns about health outcomes. And so people get excited and want to say, well, I want to find out the ACE number of fill in the blank, whoever I'm working with. And this is where we want to kind of bring in some other voices. Actually, there's some familiar voices who are maybe saying some other things that you didn't know that they were currently saying. We want to raise a little bit of a discussion regarding the use of the ACE survey and caution ourselves to think, how do we ask these questions in an intentional and in a trauma competent way so that we're avoiding re-traumatizing the individuals whom we're working with? Because, like Debbie kind of pointed out really clearly, if 2/3 or more of individuals who have taken this survey again and again and again respond with at least one ACE score, if the underlying historical traumas are in place and leading to higher chances of ACEs, if the individuals who we're working with we're engaging with them because of addiction, because of substance abuse, because of need for services in a public welfare setting, we can fairly well assume that nearly 100% of the individuals who we're working with have a history of trauma. So why are we asking them if they have a history of trauma? So here are a few quotes and a few things to think about. I would encourage folks to check out this book by Alex Chevron-Vanette, Equity Centered Trauma Informed Education. She has a chapter where she pushes back on the use of the ACE questionnaire in schools. And I thought this quote from her summarized it really well, that child trauma is far more than a number. If I'm engaging with an individual and I know that their ACE score is 2 or 4 or 6, that is interesting, that might be helpful, but that individual is far more than just that number. And I make a mistake as a practitioner if I simply summarize that individual as so-and-so has an ACE score of 7. Now I know a lot about them. There's actually probably a lot more that I don't know about them. And again, I don't need to know their ACE number to know if I'm engaging with them and they're engaging with my services, they have a history of trauma. Because I know that the research has shown me that 2/3 or more, and particularly, again, as we look at the history, it's going to be even more. Here's another quote, actually from Dr. Anda himself. I would highly, highly encourage folks to check out this YouTube video. The title of it is right there, Inside the ACE Score, Strengths, Limitations, and Misapplications. And the YouTube link is there. It's about 20 minutes long, and he himself goes through concerns that he has about how his own ACE questionnaire is being used. And he says the questionnaires commonly used are a crude measure of exposure to childhood adversity. In other words, it doesn't really tell us much unique information about that individual. It gives us a lot of information about populations, about public health, about how systems and policies are working or not working, but it doesn't tell us much about that individual. Now, I don't know about you, but when it comes to being trauma competent, I try to avoid crude measures. I try to be sensitive. I try to be respectful.
What's the
Try
date
to
on
be
it?
patient-directed,
No.
patient-informed.
It might be smell it. That's fine. I gotta go get some more milk.
Maybe can you get that one? Paula's gonna get her milk. She's all right. I did it. I've done that before too. I was unmuted on my calls before it happens. So Dr. Anda himself has concerns that this is a crude measure and we should be concerned, or we should be intentional about how we use it. So here are just a couple of more potential concerns. These are unpredictable questions that require the client to recall trauma. They may not know that they are going to be asked to answer these questions when they come in for a healthcare screening. They think that they're getting their blood pressure and their weight and their height, and they think they're going to have a conversation about their blood pressure, and then someone is asking them, well, tell me about your childhood, and did your parents abuse you? I wasn't anticipating answering that question today with you, medical assistant. Thank you for asking me that. And if we take into account what we know about some of the historical trauma pieces and potentially the cross-cultural, cross-racial factors that are at play, for myself as a white social worker asking those questions of a client who may likely be a person of color, this could again be very re-traumatizing. These are very personal questions. And whether or not they actually are required to gain access to services, the implication for the client, for the patient, is probably that they are. If you came in the door and I'm saying, well, the first thing we need to do is I need to take an assessment of your trauma history. And they're saying, well, I just wanted to get access for, I just want to come to this health appointment, or I wanted to see if I could get counseling for my kid, or I wanted to see if I could get some help with my housing. And they are required to answer very personal questions. Additionally, and this may not always be the case, but I just wonder at an agency level, how much is this data being used to change actual services received? I don't know. It may be, it may not be. I don't know. And this is kind of where the invitation is, where I would encourage all of you to do some self-reflection and say, if I have a client of an ACE score of 2, and if I have a client of ACE score of 7, do I change how I engage with them? It may be relevant, but if we're talking about supportive housing, if we're talking about a blood pressure screening, if we're talking about services in school, it may not actually change the services that the client is receiving. And so then the question is, why are we gathering the data? If we're doing public health research, that's another conversation. And Dr. Anda himself would say, yeah, we can use this for broad research implications. But if we're talking about providing services for individuals, then it may not be the case. So again, from this same YouTube video, Dr. Anda himself says the ACE questionnaire is not an appropriate screening tool. Dr. Wade also pushed back on this. He said it's not a screener, it's an assessment. I haven't thought about that very much before. And so I'm going to be thinking about what's the difference between those two words and how do we use it as an assessment? Who conducts assessments? Typically licensed professionals who have a particular need for that information to inform treatment. Who conducts screeners? And those are two different types of tools that we can be thinking about. Let me just offer one more quote and another source that I would encourage folks to look into. This is from an article that if you've been involved in trauma-informed work for the last several years, you've probably read. This comes from Sean Ginwright. His article, The Future of Healing, Shifting from Trauma-Informed to Healing Center Engagement, gained a lot of traction a few years ago. And it's an article that I return to frequently when I want to rethink, am I kind of falling down this slippery slope of being so focused on trauma, I only see the negative in the clients that I'm working with. If the first question that I have for a patient who walks through my door is, tell me all the bad things. What's wrong with you? Even if I'm saying, what happened to you? Tell me all the bad things. I'm starting from a deficit mindset. And Dr. Wade himself this morning said, we want to start from what is right with people, what is strong about them, what's working for them, what's beautiful about them, what's courageous about them. And those are places that we can engage treatment from a more respectful, trauma competent approach. I know trauma's there. Have you lived in America in the last little bit? Have you lived in the world? Okay. All right. I know it's there. I don't need to ask you that question. I want to know what's bringing you into our office today. What's bringing you into this space today? Because that's an answer I don't know. And that's what I want to find out. So Sean Ginwright says the term trauma-informed care was akin to saying you are the worst thing that ever happened to you. It was a youth who told him this. In this article, he relays the story that he was having a conversation with young Black men, and they said, "You're asking me about my trauma? You're saying that's all I am, is the worst thing that ever happened to me." It was from his clients, from the youth whom he was working with. Again, we listen to our patients. And when they're saying, "I'm not the worst thing that ever happened to me." So without careful consideration of the terms we use, we can create blind spots in our efforts to support young people. These are just some things that I think about as I think about how I use the ACE questionnaire in my work. So I want to pause and see if there are any questions or comments either from folks here or if there's anything relevant in the chat. I can kind of click on that for a second. Looks like we're okay as far as questions on the chat, but any questions or comments from folks here? And I'm going to hand it over to Debbie to shift gears a bit to talk about resilience.
So not a question, I guess, well, maybe a question, maybe a question later because I haven't formulated it yet. But when I think about sort of, this is by the way, this is absolutely correct. When I think about equity, and then we're talking, we're not even thinking about equity, and then we're hearing all these things about trauma. How do they connect, right? And that's what I'm hearing from you, Jesse. And also from you, Debbie.
Debbie, I'm gonna let you just take the camera here and maybe you can relay the question.
Yeah.
How does equity and trauma connect? And yeah.
So the question here was, because I want to make sure it's repeated so you all on the online can hear too, was kind of thinking about, it's not necessarily a formulated question yet, but just thinking about the intersections of things like trauma-informed practices and equity. Where do those two things align? And so we have, in our program, have been really challenged by that too, right? Because a lot of times they're presented as two separate things, right? You got to be trauma-informed and you have to be equitable, but really they go together. And it kind of goes back to that ACEs pyramid, I would say, in terms of understanding that we can't, I'm going to talk a little bit about this later when we talk about culturally responsive, but we cannot be competent in every single culture. We're not going to know everything about everybody, right? And about where they've been and where they've gone through. And we don't want to assume just because somebody is part of a marginalized person, population or holds one of those identities that there's a deficit mindset. We don't want to pity somebody based on those things just because we know that those populations have sustained a lot of historical trauma too, right? That's really important. We can't just say, person of color. So obviously, right? We can't make those assumptions. It's very dangerous. So where I would say that those two things intersect, as we're going to jump into universal best practices, is really about languaging things in the best way that we can, knowing that we're going to get it wrong. And so when I think about equity, I think about a quality of result and not a quality of opportunity, right? Quality of opportunity is making sure that everybody gets the same. And a quality of result is making sure everybody achieves the same, which means they might have to have different things to get to that goal. And so as we're thinking about that, those trauma responsive works, as you heard Jesse say, one of the things we need to take back to our organizations is if somebody has an ACE score of 2 or an ACE score of 7, does the way I treat them differentiate? Shouldn't, right? So just because somebody's of one of those populations, our services shouldn't change. However, if that individual, regardless of those identities, needs more, we shouldn't hold back on giving those resources. Does that make sense a little bit? Would you add anything to that? So it's more about the how we're giving things versus and I think it's a lot of self-awareness too, right? We're going to get language wrong all the time. Language changes every day, especially when we're thinking about how we're addressing people and what's appropriate and pronouns and all of the things. Taking responsibility and ownership of that, which I'm going to talk about later too, is really how we kind of bring all of those things together in a neat little package. Go ahead.
I just wanted to let everyone know the session will close in 3 minutes, but we're just gonna hop right back in.
Okay.
We'll call it a 2-minute break.
All right. We're going to have a 2-minute break in 3 minutes.
About 3 minutes.
So that's important to know too, if you're in the computer world. So don't worry, you're going to get right back in, is what we're being told here. So any other questions before we take a hard shift? Go ahead.
I guess with a lot of, things in this line of work being like grant funded or, lots of evaluations and stuff that have to go forth. I guess what is the alternative? Because a lot of I've seen it in my work that lots of questions that have to be asked are a barrier, and it does dissuade people from one, either being honest, and then if they're not being honest on these questionnaires, then basically the information is useless anyway.
100%.
Or just
Yeah.
rejecting the service altogether because they don't want to, it's very invasive. So I guess what is the alternative
Sure.
to that?
You want this one?
Sure, I have some thoughts about that.
I
Yeah.
figured you
So, yeah, so I would say some of the alternatives would be kind of in how we choose to write the grant. So we can, yeah, so the question was sometimes for grants and for programs, we have to provide some data. And so what are some of the alternatives? And so we'll touch base on this when we offer some universal best practices. But I would also say we have the data already that we can pull from general kind of public health information and general ACE information. We don't need to re-ask that directly. So I'd put that information up front. And then I would also rationalize in your grant work of saying, we are not going to subject individuals to this for the reason of respect for our clients. And so then my hope would be that the people that you are applying from grants from, if the intention of the grant is to serve clients and to serve populations that may have experienced adversity, that would be recognized and would be respected. There's really sort of this question that's kind of been lingering for me of, we continue to ask people about their ACE scores again and again and again across systems, right? And again, if we're thinking, my school is asking me about this, my after-school program is asking me this, my doctor's asking me this, my social worker is asking me this. I've just told a half dozen strangers, and we all know the job stability in those settings aren't exactly stable either. So then somebody new comes in and I'm telling somebody new. How many people am I telling about all of these traumatic things in my life? Are we all just kind of inviting people unwittingly into our own sort of research projects? Are we gathering their data and their information so we can, so we can justify our work when the data is already there? So I would recommend pulling from the data that we already have. And then when we're looking for, do I need to hit the leave and then rejoin?
Yeah.
I'll let you do it up here.
Right.
So then I would just say that when we're looking for data and of course it would depend on the grant, depend on the work, right? We would maybe want to be looking for less personal, more kind of general public information that might be more relevant. You have more kind of, I'm thinking more from a clinical approach, you're thinking more maybe from a grant approach, what kind of information. Questions. Is this re-traumatizing? Who else has this? And really, I think most importantly, why do I need to know it? If I'm being completely honest, for many of us in the field, there's something that we like to know about more trauma happening. It's interesting, we're drawn to it. There's a bit of a double-edged sword to that. And to pause and to say, do I need to know this? Does this change how I'm going to provide services for this individual? And instead, what we want to recommend, so being reflective about that, and then what we really want to recommend is we're always trying to increase resilience factors, because as Dr. Wade said this morning, as every trauma researcher and trauma therapist will tell you, we can't eliminate adversity. Adversity happens. We increase resilience so that we have a response to adversity that actually then creates that positive cycle that increases more resilience. If I experience adversity and then I have the supports in my life to respond to that, then I build strength and build more resilience for the future. So really the focus of our goal should be, what are the resilience factors that we're focusing on? So in our work, we look at these 5 connections to community, moments of success, a sense of hope, perseverance, and self-regulation. And activating one or more of these integrates with the others. Again, we saw this in the keynote presentation this morning, that as we start to ask about some things like, What are some things you're hopeful for? What brings you here today? What are you hoping for your child? What are you looking for? What are you looking forward to in your future? That those are indicators of resilience factors. Who are some of the support people in your life? And I say frequently that I think the hidden resilience factor, particularly for practitioners, because we also need resilience, is curiosity. And when I get curious about working with the clients and individuals who I have the opportunity to engage with, then I learn and see new things. And so when I can ask questions with an open mind, then I can kind of see what are some of those strengths that are coming forward. So let me just offer a couple of these universal best practices. And again, another quote from Alex Chevron-Vanette. She says, "It might seem paradoxical to say that in a trauma-informed school, we don't need to know who has experienced trauma. But the truth is that trauma is part of the human experience." I had to sit with that sentence for a little while. I'm still thinking about it. You know, those are her words, not mine, but that's something to think about. Everyone benefits from the universal application of trauma-informed practices. I'm going to steal one of Debbie's lines. She says, seat belts, car seats. Seat belts are good for everyone, particularly NASCAR drivers. Trauma-informed practices are good for everybody, particularly people who have a high history of adversity. So the practices that we're going to offer here are not anything that's going to hurt anyone. These are beneficial for everyone. Particularly, I would say they're beneficial for the people who are working in environments that have high secondary trauma, where you're working with a lot of individuals who have trauma. So what are some of these universal best practices? We're just going to name them and we'll give a few examples, but this is really, again, where the invitation is to you all to think about how can we make these things happen in our particular field. The first one that's so important is increasing predictability. The essence of trauma is when it is unpredictable and overwhelming. If something is predictable, it doesn't mean it can't be hard. We were having this conversation earlier about school social work. One of the misunderstandings of trauma-informed work in schools is that we just want to make everything easy and give everyone a passing grade. No, things can still be hard, but if I know it's hard, I can prepare for it, I can plan for it, and I can be ready for it. So as we increase predictability, that might mean saying to clients, these will be some of the questions or some of the things that we're going to need to gather information from you next time. And here's why we need to gather that information. Increasing predictability so that they know what to expect in the appointments. Something as simple as, how long is this appointment going to be? You're going to have your first intake session with your social worker tomorrow at 3 o'clock. Okay. Am I done at 3:45? Am I done at 4:30? Am I done at 5? Those things matter to me, especially if I got to pick up my kids, I got to get dinner ready, or any of the other things I might need to do for the day. So increasing predictability is a universal best practice that we can always say, how can we provide more information ahead of time about how we're going to engage with our clients, what they can expect, and how can we increase that predictability for our service providers as well. I'm going to do one more, and then I'll invite Debbie to take the last couple here. The second one that we think about is decreasing the power differential. Again, the essence of trauma is when my boundaries are violated and I lose control and I lose power. That's what happens in a traumatic situation, is when I can't control whatever is happening to me. So if I know that there is an extremely high likelihood that the individual who I'm engaging with has experienced trauma, I'm going to try to give them as much power and control as possible. But that has to be a conscious choice on the part of the agency and the part of the practitioner, because it is more likely, again, if we think about some of the systemic issues, from the start, again, myself as a white cisgendered male, I come into the room with all the power. I just got to know that. So then I got to be intentional about how am I going to decrease my power and increase the power, increase the control, increase the agency, increase the autonomy of the clients who I'm working with. So what does that look like? Always offering choices. Again, do clients have the sense that they have to answer questions and have to give me information in order to receive the services that they need? That's an unequitable power differential right there. if I hold all of the resources that they are trying to gain access to, and I'm saying, well, to gain support, subsidies, counseling, whatever it is for the reason they're engaging with me, you have to answer these questions first. That's an unequal, unbalanced relationship. And so instead, I can offer to the clients, you have the right to say no. You can opt out of any of these forms. You can tell me when you want to stop. If at any point in this conversation you need to take a break, here's what you can say. If at any point you would like to work with another social worker, you have the right to request another social worker. They have that right. Okay, and if your agency doesn't have that practice in place, those would be the things that I would encourage you to consider. Can your client say, I choose not to work with you, I would like to work with somebody else? If I have that right when I go into any grocery store or restaurant or big box store, right? They should have that right when they're working with me. How else can we decrease the power differential? We can actually work to make ourselves physically lower if we want to sit down, if we want to be sitting parallel. We can think about the physical space. And then again, giving clients the option to opt out of whatever that is that they're doing, whatever that engagement is. Debbie, maybe some other ideas about power differential, then you can hit the next couple ones.
So in thinking about power differential, I was just going to provide an example that kind of brings that predictability together with decreasing that power differential. And so we did this conference with this similar content, a different presentation title and all of that with Mental Health America a couple of months back. And they were talking about the phone screeners that they had to do, especially during COVID, pertaining to receiving some extra dollars or some extra resources and those kinds of things. And they weren't prefacing their phone calls with that, right? They would just give their client a call and it's somebody that they had a relationship with, but they would dive into the questions. What they found is their relationship was not enough, right? They were getting hung up on, they were getting cussed out, they were getting a lot of those things happening, right? Because there was no predictability to the questions about, especially income. There were a lot of finance questions that were related to that. And that's very personal to talk about how much money you are making or how much money your bills are. And I don't tell people that stuff. Why should you have to tell me on the phone if you're receiving services like from my agency, right? Unfair. That's a power differential and it's necessary. The questions may be, and maybe they're not necessary, right? But I, the person who's carrying this out, not the person who had to create the form, right, have to carry that out. And so what we encouraged them to do or to try was to eliminate that power differential right up front and put the predictability up front. Hey, I need 30 minutes of your time today, and we're going to talk about some finance questions. And if they are uncomfortable at any point, you have to let me know so that I can stop. And if you don't feel comfortable answering, you can say skip, you can opt out. We don't have to do this way. I can mail it to you if that's more comfortable than us talking via phone, because it was at a point they couldn't do anything in person. So they were trying to figure out ways around that, right? And still being personal. So they put the predictability up front and gave everybody the rundown and found that people were much more willing to talk about those things via phone with them because they had an opportunity to hear that they could opt out or say no if they wanted to, and it wasn't going to hinder them completing the application because it could be mailed to them. They could get the information a different way. So that's a way that you can kind of bring some of those intersections of trauma-informed and equity together, right? Because now we're eliminating that power differential for everybody, primarily a lot of times marginalized persons or people who hold marginalized identities. So that's kind of how those cross sections come together. And especially thinking about, even though it was via phone, sometimes they're via Zoom, right? Or via something else, or you've seen this person in real life. And we have to remember that past experiences shape the brain, right? So even if you are well-intentioned and you're on their side, if a person who looks like you, talks like you, does what you do, what fill in the blank, right, has harmed me in the past in some capacity, immediately my brain is going to go to that fight, flight, freeze and do what brains do and reject that and feel that there is a perceived level of threat. That's what brains do, right? Because past experiences shape that. And that goes back to that ACEs thing, right? We don't need to know that. We just need to know that maybe something harmful happened in the past. And so we need to put all the things out there up front, find ways to decrease that power differential, which is another intersection of how those things come together, right? Remembering that I may look, speak, sound, have a job, etc., that has harmed people in the past. And so even though I am well-intentioned, it's going to take time for me to be able to utilize that relationship and literally rewire the brain. break some neural connections and rewire new ones and create a new template. So we have to remember that that shift takes time a little bit too. All right. Did you have anything else there before I move on?
No,
Okay.
we'll pass- Are we okay?
I couldn't read your pencil. I'm so sorry. What's the,
Oh, I was saying it's 2 p.m. So
Okay.
in the next 5 minutes.
great. We can do that. Thank you. So increasing self-regulation. So this one's a fun one for me to talk about. I think about, this conference and it's linked to opioid and all the things that have gone on to that too, right? And so I have a daughter who I adopted who was born dependent to heroin, right? And she needs self-regulation more than anybody else in the world, I think, sometimes. And I have to recognize that what her needs are look very different than what my older biologic daughter's needs are, right? And so when we're talking about increasing that self-regulation with clientele, again, if you met her and I didn't disclose that to you, you wouldn't know, right? You wouldn't know she was born dependent to heroin. You're going to see that her body needs movement. You're going to see that she's over there twiddling her thumbs and trying to color a lot. And you're going to be like, what's going on here, right? That's that thing that there's more to the story, but you don't necessarily have to know it, right? So when we take opportunities to sit parallel, when we move in our meetings, if possible, there's ways to do that via Zoom. Anything that we can do to increase self-regulation. So a lot of times when we're calling people, we encourage it to be a walk and talk conversation. I can carry my phone and move, so can they, right? And it makes that conversation more comfortable, especially if we're not able to be together in real life. So finding ways to encourage movement. Movement is what the brainstem in particular needs all of the time. And recognizing, again, that's a quality of opportunity versus a quality of result. My second daughter needs a lot more of that than my older daughter. And because of that, she gets a lot more of it so that they can both be successful. So we have to work with her school so she can stand at the back of the class if she needs to. We have to work with how do we find strategies for her to be able to walk in the grocery store without knocking everything off the counter. Right? She just needs that extra so that she can have those executive functioning skills too. She needs that to be a well-adjusted adult also, but she needs it more. And so we, as providers of those resources, should kind of gauge that, see what people need, and offer that if that's the right solution. Right? And I know we're short on time, so I'm gonna speed through this last one. This is increasing culturally responsive practices. And I could spend a lot of time here. And when we're thinking about increasing culturally responsive practices, really what I would highlight is going back to that language. We are going to say it wrong. We are going to call a population by the wrong thing, even if we are trying to be, right in the know and knowing what those words are, right? Especially as providers, our forms may be outdated. We may have 2 genders you can choose from. We may have, hey, what is your mom's name and your dad's name? Knowing that some people don't have moms and dads, or they may have 2 moms, or whatever that makeup may be, right? Our forms are outdated. This goes back to auditing that internally and reflecting on what those things could be, but also how we're doing that conversationally, right? But when we get it wrong, because we will, how do we own that? Because that decreases power
Good afternoon, everyone. We will be starting the virtual panel session here in a few minutes. So if you would like to join the panel session, please utilize the third Zoom account that is just uploaded in the chat. Is the Ohio CHSP Zoom account. Again, it is, oops, not that one. For again, the panel session, you will want to use this account. Or either if you registered later yesterday, this instructions document with the Zoom account information. And in a few minutes, I will be closing this session. So again, you will just want to log into this Zoom account.